I'm Eileen Doherty, and I'm the director of the Colorado Gerontological Society. And today we're going to talk about the Colorado Aid in Dying bill and legislative or constitutional amendment that was passed a few years ago as part of our advanced care planning series. So 2016, the Colorado voters passed a bill called Death with Dignity: Options at the End of Life. And it had three major features in that constitutional amendment. One was it allowed terminally ill individuals with a prognosis of 6 months or less to live to be able to request and self-administer medical aid in dying medication voluntarily to end their life. The second thing it did was it authorized physicians to be able to prescribe medical aid in dying medications without criminal penalties. And the last thing it did is that if you, in fact, use the medication and you were not authorized, that you could, in fact, then be prosecuted for criminal penalties if it was not used properly. So the Colorado law went into effect shortly after that. In the last legislative session, they made some significant changes. So that's what we'll talk about, the law itself and what it provides for, as well as some of the utilization. At this point in time, the legislation allowed for the Colorado Department of Public Health to promulgate rules as well as to manage the program. So the major changes that we looked at in the last legislative session had to do with who could prescribe, a little bit better definition of informed consent, changing the wait times, improving the mental health professional referrals if necessary, informing significant others of your intent to use medical aid in dying, continue to protect prescribers who don't want to prescribe, and instituted basically the life insurance has to pay if, and they cannot exclude medical aid in dying as one of the factors in which they won't write a policy. So let's take a look at the various things that they changed or added, as well as things that were just continuing on. So the biggest, or one of the biggest things they did is originally only physicians could prescribe medical aid in dying and be a part of that decision if anyone decided to use it. So now an advanced practice registered nurse can do medical aid in dying as well. Both physicians and nurses have to be licensed, certified, or registered to be able to administer medications as part of their practice. And they also have to be able to diagnose the underlying diseases or causes. And then they also have to be able, based on their medical knowledge, to determine whether or not the individual is terminally ill. In terms of informed consent, one of the additions that they made was that the person had to be mentally capable to request and obtain a prescription for the medication. Now, that has always been there, but there has been some concern and confusion over the years about whether or not the individual was actually mentally able and capable to make informed consent. So they strengthened the language a little bit to be able to do that. The other thing in terms of the informed consent is that the individual has to be able to self-administer to bring about death. If I am helping my husband with medical aid in dying, then I can be prosecuted for homicide or murder, or assisted suicide. but if he can administer it himself, then he is able to do that. There are two providers that have to be involved with this. One of them is the attending physician, and then or provider, and then they make a really big deal and have created a specific set of responsibilities for a consulting provider. Again, I think that these are good protections, if you will, for all of us to be able to take advantage of medical aid in dying as an alternative method to passing on, if that is our choice. So the healthcare provider, this is the nurse and the doctor, they have to inform the individual, and it's very specific about the diagnoses and prognosis. They have to talk with them about the risk of taking the medications. I read some stuff where often it takes about 3 hours for the process to happen. Sometimes it happens more quickly, sometimes less quickly. What the result is of taking the medication, they have to document that they discussed other end-of-life options such as hospice, palliative care, comfort care, and they have to discuss the right, if you will, of the individual to withdraw their request for medications should the individual decide that they do not want to participate in the medical aid in dying program. So the legislature strengthened the definition of medical aid in dying. So an advanced practice nurse or the physician have to be able to evaluate the request from the individual. They have to have that skill set. There's no indication in the legislation that indicates how you get that, what you use to evaluate it, but it says that you have to evaluate the request. The second thing that you have to do is you have to determine whether or not the individual qualifies for medical aid in dying. This is basically whether or not it is a diagnosis that is not necessarily meets criteria, but is terminal, and you have to be able to determine whether the individual has 6 months or less. Mental capacity receives a lot of conversation in the statute as well. And then you have to get the individual to sign an informed consent form, and you have to then be able to prescribe the prescription. So if you as an individual decide that you would like to request medical aid in dying, there is a process that you must follow. So you have to make the request orally twice, at least 7 days apart. This is a change. It was 15 days apart. You have to submit a valid written request, and we'll look at the language of that here in a moment. There is language both in the statute as well as on the health department's website. And you have to make the request yourself. It cannot be done by a power of attorney or a guardian. The 7-day requirement, if in fact the individual requesting medical aid in dying, and it's the determination of the medical provider that the person has less than 48 hours to live, that they can in fact waive or make note that the 7-day request for oral requests can be waived. This is the form that is pretty much taken from the statute. It is also the form that is on the health department's website. And so I suggest that if you know people or you yourself are considering using that, that the easy thing to do in terms of requesting the medication is to use this form, because then there aren't any questions about whether or not you are doing it in the proper format. I will take questions at the end of
I'm
this.
pissed.
Actually, Eileen, I'm so sorry, but we're not seeing your slides. I'm only seeing the title slide, so I'm not sure
Oh,
if
okay.
you shared it right or something.
Okay,
So
well,
sorry, it wasn't a question, it was just making a comment.
okay, sorry about that. Thank you
That's
for
okay.
letting me know that. So let's see if I can get these to, let me just start all over on the share and see if I can get it to do what it needs to do. Did that help?
Yes, it did.
Okay. Okay, let's see. So I should go to from the beginning. Okay, why are you not?
Do you by any chance have a second screen that it's putting it on?
So I had an Amazon gift card and I thought I would go to redeem it. But I pulled the little thing off and you can't read all the numbers. So my
So what
first
does
step
that so what
was
does that have to do with
I
this
went into City
presentation?
Market and
Okay,
told them that.
maybe we can talk
Because
about
I
that.
wasn't sure
Let me
if,
see if I can get the rest of it off.
Yeah, let's
Okay.
talk about that afterwards, okay? In the question and answer.
you can see, but that's not the problem though. So City Market said I needed a contact.
Okay, I got to get this thing to advance. What is wrong here? Stop share. Okay, so share. Oh, I'll bet it's over here. Okay. Okay, can you see the request form at this point, Christy?
Yes, yes, thank
Okay.
you so much. That's so helpful.
Okay. Is it helpful to go back a couple?
I'm okay if you don't. Maybe, are you going to be sharing these afterwards?
I'll send them
Oh,
out.
okay. Yeah, I think you can just keep going where you're at.
Okay,
I don't know if anybody else agrees, but
sorry for the disruption.
nope, thanks for doing that.
No problem. Sometimes you get started on these things and I see different things than you guys see, so that's always a challenge. So this is the form that the is in the statute, and it's pretty prescriptive, but it basically says that gives your name, what you're suffering from, tells the health department that you have been informed of your situation, your prognosis, your diagnoses, what will happen, says an acknowledgement that you understand that you can stop the request at any time, that you understand what happens if you take the medications, and that, you know, the time frame when it may take for it to take effect. It does have to be witnessed, and there is a specific indication that if, like, I can't witness it for like my husband or a domestic partner, and it cannot be somebody from a healthcare facility. So again, just making sure that you get the right witnesses is important. So as I said a few minutes ago, you could always rescind your request. And I'll talk a little bit about how frequently that seems to be happening in a little bit. So the provider's responsibilities then, we have kind of gone over this, but this is what the nurse and or the doctor are required to do. So they have to arrange for a consultation to confirm the terminal illness as well as mental capacity. So there's a group of physicians and nurses now that can provide it can be the attending physicians, and then there's a group of physicians and nurses that can serve as the consultants. If the provider, the attending, has any question about your mental acuity, they have to make a referral to the licensed mental health professional. They have to educate you to notify your next of kin or any significant others. They have to inform you that you can change your mind, and then they dispense the medications directly either to you, or they can send a prescription to a pharmacy requesting the meds be given to the provider, the individual, or to a designated individual. And the designated individual, I believe, is also new in the current statute. When you get to the consulting provider, they need to examine all of the medical records. They may or may not ask to see you in person, but based on the medical records or on an examination, they have to confirm again in writing back to the attending that this is a terminal illness, that there is a prognosis of 6 months or less to live, that you're making an informed decision, that you have the mental capacity to do it. And they are the ones who confirm that the prescription has been ordered. If there's question about your mental health or your capacity to make an informed decision, then they have to refer to a licensed mental health professional. So again, there's a lot of different types of mental health professionals, but we have to make sure that it goes to a licensed one. So that could be a psychologist, it probably could be a licensed clinical social worker, could be a psychiatrist. Those would be the types of individuals that would come to mind off the top of my head. The statute is not specific about the type of mental health professional, they just have to be licensed. The mental health professional then has to examine you and submit a written report to the attending provider and or to the consulting provider. And then if you are determined to not be mentally capable, then the prescription cannot be written. The documentation required by the attending for mental capacity is that they have to add that to their report. So there's a second report, if you will, that has to be filed with the health department. They have to confirm the diagnosis and treatment or the prognosis is less than 6 months. And they have to attest as well that they have followed all of the state rules and document that before it can basically proceed. The medications that are used most frequently in Colorado, and I got these off of the Colorado website, is diazepam, digoxin, morphine sulfate, and propanol, a substitution of propanol with amitriptyline or some type of phenobarbital. So that's the type of medications that they're using. It's important to know that the federal government or your Medicare is not going to pay for this if you are an older adult. What that does is it sets the precedent that if you have a group health insurance, an employee retirement health plan, or Medicaid, they're not going to pay for it either. But the medical professional has the ability to file a claim against your estate to cover the costs of the medications and any associated attorney's fees. They can also, if you have the cash, you can just pay for it upfront when you get the medications. In terms of the death certificate can be either signed by the attending physician, or if you are working with a hospice, and this is one of your choices in the hospice care to use medical aid in dying, then the hospice medical director can sign the death certificate as well. So life insurance companies who are doing business in Colorado cannot deny or alter the benefits available to an individual with a terminal illness based on the availability of medical aid in dying. So what that really means is that if you either have a current life insurance or you are purchasing a new life insurance, they cannot deny a payout of your life insurance if so they cannot deny it. They cannot say that it's a non-covered incident, either in an existing policy or in a new policy. So that is, again, a protection for individuals who want to use medical aid in dying and are worried about their health insurance being able to pay out as a result of that. If there are unused medications, the individual who has taken their life has to designate someone in terms of disposing of those medications. So you kind of have two options. One is that you can return them back to the attending physician, and it becomes then, or provider, and it becomes their responsibility to dispose of the medications. Or you can participate in one of the give back or drug give back days that the federal government does under the Secure and Responsible Drug Disposal Act of 2010. We used to see lots of those around in the past years, and actually the Gerontological Society participated a number of times in increasing awareness about where you could do that, but those have become less popular over the last few years. And so I don't see much in the way of advertisements that those are available. And if somebody asked me where to dispose of those, even your just regular medications these days, I don't have a really good set of resources for that. Another thing that the statute provides for is immunity for the attending provider. So what this really means is that if the attending provider, the doctor or the nurses, follow all of the procedures of the law, then they cannot be prosecuted under the criminal code for suicide, homicide, assisted living, mercy killing, or I was pleased to see elder abuse in there as well. We're getting more and more concerned, if you will, that a lot of things are being labeled as elder abuse. And unfortunately, that is a very serious accusation. And if there is a lower standard of proof, if you will, for being accused of elder abuse, and if your name goes on the Colorado the CAPS registry, which is the Colorado Adult Protective Services Registry, as having been accused of elder abuse, and if the investigation by the Department of Human Services supports that there was elder abuse, it very much limits your ability to work, especially in healthcare kinds of settings. So I was pleased that if you follow the procedures, that they cannot make that accusation. There's been a lot of concern over the years and a lot of public discussion, a lot of media attention to what if an attending provider really does not believe in medical aid in dying and does not want to participate in providing medical aid in dying treatment or care. The provider has the right to let you know as the individual that they do not intend or that they do not participate, and they can make a referral to a new healthcare provider. They are obligated to transfer all of the relevant documents to the new provider so that they can proceed with providing the medical aid in dying care. Similar to individuals being able to opt out, healthcare institutions such as a hospital can also opt out in providing medical aid in dying. They do have to notify their staff and providers at the time of hiring of their policy in writing. They have to also annually notify staff and providers if they do or do not participate. The provider then can provide the individual, again, with information about their health status as another treatment alternative. You can still let people know, even if you're working in a facility that's not going to participate. So this next section looks a little bit at who is using the program. So in 2023, there were 389 prescriptions written. That's a 22% increase from 2022. There were 294 prescriptions dispensed to qualified individuals, and there were 333 death certificates issued in 2023. So not a lot of people are using this option, but there is a group of people that are choosing this as the way to take to have control over their last days and hours. Demographically, what we see, again, this is in the 2023 report from the health department, is that, as I said, 333 people used medical aid in dying. The median age of people was age 75. 93% were white, 44% were married, and a little bit higher proportion of men versus women who used it, but not a real large range. I would have expected that range to be a little bit higher, but it wasn't. The most common illnesses or conditions are cancer. And there was a whole list with pancreatic cancer being the #1 disease or cancer that people used medical aid in dying. A lot of progressive neurological diseases such as ALS, Parkinson's, MS. Cardiovascular came in as 3rd, and this is heart and stroke. And then the last one was lung diseases, primarily chronic obstructive lung disease. This one is a little bit interesting, and the only thing I could conclude is that some people got scripts in 2022 and did not use them, because we see that in the previous slides, 333 people used their medical aid in dying script, but only 316 requests were processed in 2023 from providers. And then of those, 304 patients or individuals actually requested medical aid in dying. And then of those, 300 consulting provider reports were provided, and then 299 medication requests. What I concluded from this is that once people have made the decision to do medical aid in dying, at least in 2023. They were pretty consistent in terms of following through with that plan or that method of death. Because we don't see much variation from 316 people or doctors filing the initial paperwork to 299 actually requesting the medication, and 333 from the previous slide actually having death certificates. So we have to conclude that there was a group of people who requested the medication in 2022 and did not use it. So that kind of concludes my remarks at this point in time. Just to give you a couple things about the society. Some of you may know that our vision and hearing dental programs have suffered a significant loss in funding. So if anybody knows where we can secure $100, $200, $300,000 to refund those programs, we have some work in progress that we're working on, but right now we're not accepting new applications. We do have some funding that we'll be able to use for the next few months as we look for additional sources of funding. The dental services were refunded, and so we do have approximately $300,000 of dental monies that we can pay. Those are primarily for people who live in Metro Denver, as well as anything west of I-25. We have a telephone buddy program where you can get a call from an older adult, or as an older adult from someone in the community to just kind of check in on you. We have some mental health counseling, but that's limited to, at this point, people who live in the city and county of Denver. Our advanced care planning series, in addition to this particular series of programs that we have been doing, we also have can do some individual counseling, etc. And we are doing our Salute to Seniors on August the 24th at the at the Greek Events Center, which is at 4610 East Alameda. We have pushing 50 vendors signed up and hope to get another 25 or 30 over the next few weeks. We also have a series of educational programs. We have lots of giveaways. Some of our special features include some type of a health fair, some type of farmers market where you can get free produce, looking at lots of free giveaways for snacks, having a mini health fair, some tips for mental health services. So we have a kind of a variety of things that will be going on that day. And look for our information to be coming out shortly about that. We have most of our Medicare Monday planned for the fall. That will start on October the 14th. And some of those sessions will be on Zoom and some will be in person. I'm not sure all of that is posted yet on our website, but should be shortly. And with that, I thank you for your attention today.